Hi everyone, my name is Dr. Krawczyk, and I'm an internal medicine and pediatrics resident physician at Loyola University Medical Center.
And I'm Dr. Akbulut. I'm also an internal medicine and pediatrics resident at Loyola University Medical Center.
Let us tell you a little bit more about a progressive autoimmune liver disease known as primary sclerosing cholangitis, or PSC. In PSC, we see both inflammation and fibrosis of the intra and extrahepatic bile ducts. This causes bile duct stricturing and several other complications like reduced bile flow, increased biliary pressure, and further cholestasis. Up to 16 per every 100,000 individuals have been found to have PSC. Around 50% of patients also have concurrent IBD. 70% of patients are also male. So how do we diagnose PSC? We could start off with a really good history and physical. We have to talk to and examine our patients. Then we could get some lab chemistries, obtain some LFTs, and we could consider PSC when there's a cholestatic pattern. We should also rule out secondary PSC. We can obtain some imaging, like an MRI, MRCP. If it's equivocal, we repeat the MRCP. If it's normal, we should be considering a liver biopsy. We always should get a serum IgG4 to exclude any IgG4 sclerosing cholangitis. And we should be getting a colonoscopy with biopsies as well. We'd like to avoid ERCPs if we can.
Like other autoimmune conditions, PSC has many systemic symptoms and complications. These could include brain fog, difficulty concentrating, and full body fatigue. However, the complications and symptoms that are unique to PSC typically involve issues with the hepatobiliary system, such as biliary strictures, portal hypertension, and hepatic cirrhosis. Some examples of these include pruritus, which is secondary to bile acid buildup, steatorrhea, malnutrition from poor gut absorption of nutrients. The culmination of this pathology can put patients at risk for hepatocellular carcinoma, cholangiocarcinoma, cholangitis, cholelithiasis, fat-soluble vitamin deficiencies, vitamins A, D, E, and K, and decreased bone density, which can result in osteoporosis.
Key feature on histology is going to be the onion skin fibrosis.
Unfortunately, there are no established medications or treatment regimens for PSC. All clinicians can do is have a high index of suspicion and manage and treat complications and symptoms as they arise. Deoxycholic acid or off-label vancomycin can be used, but the data is limited in their utility. Pruritus can be treated with antihistamines, heat avoidance, emollients, and/or bile acid sequestrants. With this disease process, it is important to stay up to date with screenings, getting your endoscopies, including UGDs, and colonoscopies when indicated.
We also screen for fat-soluble vitamin deficiencies and make sure our patient is following up with a nutritionist.
Through shared decision-making with our patients, we can also determine when it would be best to perform a DEXA scan. ERCPs can be done to evaluate for strictures, new pruritus, weight loss, and other issues that come along the way. But ultimately, a liver transplant may be needed if patients develop end-stage liver disease. Yearly cancer screenings are very important, especially those to evaluate for colon cancer, cholangiocarcinoma, and hepatocellular carcinoma.
Here are some key points. PSC is progressive. Many patients end up developing end-stage liver disease. There are no approved medicines to treat PSC at the moment. The management usually involves treating complications and symptoms when they arise. Thank you guys so much for listening to this presentation.